It is 9 o'clock. I think there will be more people joining us, but let's make a start and they can just join us late.
Okay, that's fine. Well, they can watch it otherwise anyway, can't they? So. Okay, so I was just going to talk about... So I was going to talk about vascular disorders, and I essentially used the suggestions that you made at the start. So I'm going to talk a little bit about aneurysms and try and keep it as interesting as I can. Talk about dissection, which is probably fairly short talk, really. I was going to focus on the imaging aspects, and then talk about thrombosis. And with thrombosis, I was going to focus on dural venous sinus thrombosis a little bit, and stroke, because those are the main things really, intravascular thrombosis that affects the brain. Okay, so I was going to break the aneurysms down into their morphological types. Okay, so there are these are the main different types of aneurysms. You can talk about different aneurysms in terms of locations, or you can talk about them in terms of their actual morphology. So you can get saccular aneurysms. Saccular aneurysms are your typical aneurysms that present acutely with acute subretinoid hemorrhage. And a subtype of these are giant aneurysms, which are actually defined as anything over 2.5 centimeters. But they're pathologically and etiologically, well, etiologically is difficult, but pathologically certainly distinct from your typical saccular aneurysms, which spontaneously rupture and cause subretinoid hemorrhage. Then we've got fusiform aneurysms / dissecting aneurysms. There's a particular type of aneurysm called a blister-bleb aneurysm, and then I was going to talk a little bit about mycotic aneurysms. All right, so saccular aneurysms. So this is a nice paper that you can look at, and this paper is a paper written fairly recently, and it was in Stroke, which Stroke's a great, I mean, you're probably all aware of Stroke, it's a great journal, and it's very well regarded in terms of neurovascular, papers and stuff. And Stroke, there's a review there, and it's this one, and it essentially talks about unruptured aneurysms, and we use it in the MDT in order to guide our treatments, and it's a good paper to get a basic understanding of unruptured aneurysms. So anyway, saccular aneurysms, they're actually weak dilatations at the major bifurcations of the arteries of the brain arteries. The common locations include the anterior communicating artery complex, the middle cerebral artery bifurcation, at the origin of the posterior communicating artery, the basilar termination, and at the origin of pica. You're not born with them. They're essentially an acquired degenerative process of the arteries, and that can be due to either lifestyle factors, or it can be due to just the actual shape of a person's circle of Willis can predispose to acquiring cerebral aneurysms. They have a prevalence of approximately 3% of middle-aged adults. So if I speak to someone in one of the clinics who has an unruptured aneurysm, usually say that between 1 to 5% of people, everybody walking around has a aneurysm. And obviously the vast majority of those people have no idea that it's there. The risk of incidentally detected unruptured aneurysms is usually less than 1% per year. So the risk of rupture, that should say. So what I need to say essentially is that 1 to 5% is not vanishingly uncommon, and it's an awful lot of people out there that are walking around with unruptured aneurysms. But the point of it is that the vast majority of those will never rupture. Less than 1% of them rupture, and the natural history of an unruptured, incidentally detected cerebral aneurysm is actually very benign, much more benign than people attribute to it. So essentially, these are all the factors that are associated with rupture of one of these saccular aneurysms, your typical aneurysms that you see in subarachnoid hemorrhage. So all these are hazard ratios and risk ratios, and these are from that paper that I've already told you about. So things like patients with high blood pressure, patients that smoke and that drink are at higher, if they've got an aneurysm, they're at higher risk of rupture. If they're younger with the aneurysm, they've got a higher risk of rupture, and that's simply because they've got longer to live with it. So the cumulative risk of rupture over their lifetime is increased. Geographical location. So the Finnish are well known to have very high incidences of subarachnoid hemorrhage, and also in Japan as well. So more than in Western populations, it's more common in Finnish people. Well, obviously Finland is Western, but I mean Western Europe and America. The women are much more, and you've probably seen this on your own calls, that a lot of the subarachnoid hemorrhages do tend to be women. The aneurysm size is a factor associated with rupture, and one of the old cut-offs in NDTs was that, you know, if an aneurysm was above 7 millimeters, there was lots of evidence that that might be at a higher risk of rupture. And then there are different locations which are more prone to rupture, and one of the most dangerous locations for an aneurysm is the PCOM. So the PCOM, incidentally detected PCOMs of a reasonable size get treated, because they tend to be more risky than the other ones. Sometimes we might look at an aneurysm in the MDT, and if we think it's irregular and it looks a bit nasty, that's something to take into consideration. Aneurysm growth over time on serial imaging is a factor. There are new areas of research which you either believe it or you don't, and a lot of new MRI systems with high strength magnets, so 3 Tesla magnets, which we're going to get in, which was being installed at Salford, we're about sort of 10 years behind the curve. But you can give contrast to these and image the aneurysm in very high definition, and you can look for enhancement of the wall, and that's considered to be possibly related to inflammatory process going on within the wall, and therefore a risk of an indicator of impending rupture. Okay, so I can't actually see all my diagrams on here because my face is in the way, but I'll just talk through it. This again is from stroke, and this is a nice indicator essentially of all those points that I've just spoken about. So you can see here that this is a color-coded map of riskiness of aneurysms. So you can see here that high risk is the PCOM. Lower risk is things like the A1, A2 junction, no, that's parophthalmic aneurysms. The ACOM is a medium risk. MCA's on the lower end of the spectrum. Vascular is kind of an orange sort of medium to high risk. So I can go through all of these. That's a pica aneurysm on the origin of pica. That's a vertebro-basilar junction aneurysm. That's an ICA aneurysm. SCA, basilar termination. All of these are all just grouped together as posterior circulation aneurysms. The PCOM here, and the parophthalmic aneurysms. Parophthalmic aneurysms can cause symptoms in different ways, which might necessitate treatment. So we have quite a few patients every year that come in with eye symptoms. They might have diplopia or blindness and things, and it's because the this aneurysm grows, and your optic chiasm is just in front here, in between here and the acon, and you can get compression of the optic chiasm causing symptoms, and then you can treat it in that way. There are lots of scoring systems that we use in the MDT, and these are used to dictate treatments, essentially. So we look at all these different factors: size, location, shape and irregularity. You can look at these things where you look at the size of the aneurysm versus the width of the neck, okay? And that's called an aspect ratio. And though certain aspect ratios are at risk of rupture, but also certain aspect ratios indicate how difficult the aneurysm might be to treat, because essentially, you know, over 90% of these do get treated endovascularly, very high proportion. And if you've got a width which is very broad, it can make coiling difficult, because when you put the coils in, they can prolapse into the parent vessel, and that gives an increased risk of thromboembolic complications to the procedure. This is what I was talking about earlier in terms of vessel wall imaging and vessel wall enhancement. This is a high resolution MRI, and you might get some enhancement of the aneurysm dome, which could indicate that this aneurysm has got an inflammatory process ongoing within the wall of the aneurysm and might be at risk of impending rupture, because we still don't really understand the mechanism behind aneurysmal rupture. We just don't understand it. There are pro-inflammatory processes that are involved. There are flow dynamic processes involved, and there are well-established papers that show that the incidence of subarachnoid hemorrhage is actually higher during the autumn months, and that coincides with the flu, and more people, and they've shown that incidence can mirror incidence of influenza in populations. So there are lots of things that go on that we don't really understand yet. We use this score, which is the unruptured aneurysm treatment score, and that's a scoring system based on a patient's age, whether they smoke, how difficult we think it's going to be to treat it, irregularity, size, and we use that for every unruptured aneurysm in the MDT. So every aneurysm that comes to the MDT and gets discussed, somebody fills out a little form in the MDT, and then that score gets recorded in that patient's MDT note, and it's either for or against. And you find that probably at least 8 to 9 times out of 10, these patients are conservatively managed through our MDT. That can't be said for other departments in the country, because a lot of other departments are more aggressive with what they do, but we're traditionally quite conservative in Manchester, and I think that's probably, and we all agree, we all think that that's the best way. Okay, so I was going to talk a little bit now about giant aneurysms. So giant aneurysms are big aneurysms, which are defined as above 25 millimeters. So we see them fairly often. And there was an interesting one this week, actually. I don't know if any of you saw it. I don't know how, I think the patient's quite unwell. But anyway, we'll talk about that. Well, I haven't got the pictures of that anyway. So they're histopathologically very distinct from your usual cerebral aneurysms. They tend to be partially thrombosed and contain intramural hemorrhages. They tend to be at lower risk of causing a subarachnoid hemorrhage and tend to cause problems through their mass effect. Okay, I was going to talk a little bit about it. So this is an example from the literature, and this is a recent example from Salford, I think a couple of months ago. So this is a vertebro-basilar junction aneurysm, and this is a DSA. And you can see that this is the filling lumen of this particular giant aneurysm, which is above 2.5 centimeters. The lumen on the imaging is shown here. But most of this is actual thrombosis within the aneurysm. We're not quite sure what the pathology of these, the pathological mechanism is that goes on with these. Some people have said that these are an atherosclerotic process, whereby you get degeneration of the wall and you get bleeding within the wall of the aneurysm, and then they tend to grow, sort of like where you get abdominal aortic aneurysms are kind of a disease of 60 to 70-year-old male smokers, similar to popliteal aneurysms and aneurysms that are shown in the body. These giant, partially thrombosed atherosclerotic aneurysms are felt to be an atherosclerotic process that occurs in the brain. Another interesting thing is that vasa vasorum, which are the tiny blood vessels which nourish the arterial wall in your body, they're not found in the brain. So when you are born, the brain arteries are pathologically and histologically distinct from arteries that are seen in the rest of your body, in that they don't have vasa vasorum. These vasa vasorum develop as you get older, and they develop as you get problems with atherosclerosis and things. And one of the mechanisms for these things bleeding is that you get repeated hemorrhages into the wall of the aneurysm, which causes the aneurysm to grow. And this was a patient here in Salford. You can see here that I can't see the CTA because let me just get myself up there. Yeah, I can see it. So this patient presented. She actually presented with kind of headaches and confusion and stuff, and this is what was on her plain CT. And then you can see that there's areas of calcification within the aneurysm wall. On the CTA, there's only this bit that's actually filling, and this is a PCOM. So the PCOM, it's grown all the way back, and now it's compressing a brainstem with signal change. And she actually had a little bit of hydrocephalus with it as well. So, as I've said just then, another sort of slightly different aneurysm is a fusiform aneurysm. Okay, so we've gone from saccular, we've talked about saccular, we've talked about giant saccular, and now we're going to talk about fusiform aneurysms. Fusiform or dissecting aneurysms is essentially, it describes the shape of the aneurysm. So instead of it being a saccular aneurysm, whereby you get a distinct parent vessel, and then you get like a sac coming off the parent vessel, a fusiform, as you're all probably all aware, is essentially a dilatation of an aneurysmal, pathologically aneurysmal dilatation of the parent vessel itself. So a lot of the time, we think that these are caused by a dissection. So a dissection into the arterial wall. So a dissection is where you get a damage of the intima, so of the endothelial surface, and then you get circulating blood enters into the arterial wall, and it creates a false lumen, which gets filled with blood, and that can be called an intramural hematoma. That false lumen may re-enter the true lumen, or it can end as a blind-ending pseudoaneurysm, which might rupture and cause a subarachnoid hemorrhage. So this is a good example of a young man that we treated in Salford. He was treated in 2020 or end of 2019. He was about 30, I think. He was about 30, so he presented, as you can see here, with an acute subarachnoid hemorrhage, blood in the basal cisterns, blood in the sylvian fissures, a bit more so on the left. As you see, it's slightly asymmetric on the left side. There's blood in the interhemispheric fissure. and there's blood in his here. You can see that his temporal horns are slightly dilated, in keeping with probably early hydrocephalus. So he had a CTA like they all do, and then you can see on his CT angiogram that he's got an abnormal left middle cerebral artery, and this is rather than it being a saccular dilatation off the parent wall, it's a fusiform dilatation of the artery itself, and it's clearly in a wrong location. If this was a sort of a classic MCA saccular aneurysm, it'd be off the bifurcation here. A lot of the time, when you get these dissections from imaging, you can see a stenosis proximal to the dilatation. So we think that what could have happened here is that this has dissected around here. There's created a false lumen, and then it's resulted in this aneurysm. This is the DSA that you can see here. These are really difficult to treat. As you can tell, to treat this, you can't treat this with coils because there's nowhere to put the coils. To treat it surgically would be very difficult because you've got all the lenticular striate perforators around. You've got no real purchase on putting a clip on that. So what we tend to do with these is we use what are called flow diverter stents. And flow diverter stents are really quite a revelation in endovascular treatments of things. They're only used in the brain. So these are, let me just show, there we go. So these are stents that are very interesting. They're not covered stents. So you place the stent across the wall, across the neck of the aneurysm in the parent vessel, okay? They're made up of very fine interwoven wires. It creates a high surface area of wire. When the blood goes through, it doesn't actually close the neck immediately. The blood goes, it just essentially redirects or flow diverts blood away from the aneurysm and along the vessel proper. Over time, what that does is you still get blood going in here, but instead of it going in and straight back out again, it becomes turbulent and it promotes thrombosis, and you end up closing the vessel, closing the aneurysm through the flow diverting effects. And that has a lot of advantages in that it allows you to treat these tiny thin things that you can't get any coils into. But also what it does is it allows aneurysms that have lots of mass effect to when they thrombose, you get healing by the body and the actual aneurysm shrinks and goes away. So this can be interesting for people like this person here, that when treated with a flow diverter, there's a chance that this can actually close the sac and in a way allow the body to break this aneurysm down and it completely disappear and relieve its mass effect. And it works the same for parophthalmic aneurysms, which can press on the optic chiasm and the pre-chiasmatic optic nerves and cause diplopia in that way. All right, so this was a good one. So you can see the stent there, and this guy did well. He had a follow-up angiogram which showed that the aneurysm was completely gone at about 6 months. The difficulty with these patients is that they have to be treated. They have to be given dual antiplatelets, because if you put metal inside a vessel, it tends to promote clotting and thromboembolic complications. So these guys have to be loaded with dual antiplatelets, which is obviously a bit of a counterintuitive thing in someone who's got blood in the brain, giving them very high dose prothrombotic things that completely disable their platelets irreversibly. You know, it's a risk-benefit scenario with these. The other key thing for this is that once he places that stent, this aneurysm isn't immediately treated. So when you get patients with subarachnoid hemorrhage and they've got a saccular aneurysm and they end up getting coiled or clipped, that aneurysm's secured, it's gone. immediately after this procedure, this aneurysm isn't secured because it would still be filling. It takes a few, weeks and months for this aneurysm to thrombose due to the flow diverting effects. Some people can place a catheter here, then place the stent so that you've created a nick and then pack the aneurysm and close it that way. Obviously that's risky and difficult, and in this case that wasn't done. This is another patient, a different patient this patient presented end of last year at Salford, and he was a young man who presented with this pericallosal hematoma, unusual shaped bleed, and then the CTA, this is the CTA, but it's not showing the vessel, showed this tiny little fusiform aneurysm exactly on the pericallosal artery, and that was the reason why he's had his bleed. You can see this again is near eye impossible to treat. There are people that are putting very tiny flow diverter stents across this. We're not really doing that yet because we felt as though this hematoma has probably damaged any arterial territory supplied by this pericallosal artery. So what we did the simple thing really, and we placed a small catheter and we went across the aneurysm and coiled it all the way back and sacrificed the artery. And he didn't re-bleed, and he woke up as was before he went under, and there was no additional problems because of his vessel sacrifice. But I mean, a bad pericallosal bleed can cause quite significant problems. So now I was going to talk a little bit about blister bleb aneurysms. Okay. So again, these are they have a distinct radiological definition which is separate and different to the other aneurysms which I've just discussed with you. So they arise from non-branching. So all the other saccular aneurysms we talked about tend to arise from branching sites. They're not caused by dissections, and they classically arise off the posterior wall of the supraclinoid internal carotid arteries. They're a rare cause of subarachnoid hemorrhage. Tends to be in more younger people. The blood load seems to be higher. They're very difficult to treat, and they're also at higher risk of rebleeding because it's just a sort of friable, shallow bleb on the back of an aneurysm. This is an example of a young woman, again, recently presented in Salford. This was a CTA. The interesting thing for this lady is that when she presented, she had a CTA which was reported as normal in Salford. She actually had a digital subtraction angiogram which was reported as normal. And then a few days down the line, she ended up with a CTA again, because obviously there was a lot of unease about her because she was young, she was early 30s or whatever. And a lot of the time, depending on clinical scenario, case by case, these patients have repeated vascular imaging to see if something develops. You can see she's got vasospasm. So this was done at, maybe sort of 6 or 7 days after her ictus. And you can see here that she's just got this tiny little bulge on the posterior surface of her, this is the clinoid, of her supraclinoid ICA. This was the CTA. Oops, it is. And then on the DSA, it had grown. So obviously this is an unstable blister. Again, it was treated with a flow diverter stent, and she had a good outcome. What can see about this? So now I was going to talk a little bit about mycotic aneurysms. Mycotic aneurysms are, again, pathologically different to all the other aneurysms I've spoke about. It's a bit of a misnomer to call them mycotic aneurysms because they're very rarely caused by fungus. I think I read in a paper somewhere that the reason they call them mycotic is because they have like a mushroom shape to them, which is a bit not sure about. It's caused by infection of the vessel wall. So what happens, these patients tend to be infective endocarditis patients or drug users with, infected, they have infected DVTs and things, and you get these tiny little infected thrombus that travels around the body, and then they get lodged in the small peripheral vessels of the brain. They invade the vessel wall, and then that causes an aneurysm. You can also get them around the ICA and from people that have got quite bad paranasal sinus infections as well. Quite rare. There's a bit of a controversy about how to treat these. If they're sort of detected incidentally, if you like, in a patient with endocarditis that might be, say, imaged for stroke or something like that, or whatever, then a lot of the time people just treat them with antibiotics and then do serial imaging to make sure that the aneurysm is stable. If it ruptures, or if the vessel starts to grow, then the vessel needs to be sacrificed. There's no other way to treat these. They're so distal. This is one in a patient, tiny little aneurysm, very, very distal, all the way up here. This one hadn't ruptured, but it was treated at a different centre, whether a bit more aggressive, and it was growing, so they went for it. On the DSA, you can see here, this is a subtracted image, but the carotid artery is all the way down here, and we've got this tube all the way out here, and all the way up to there. And then this is glue. So we're injecting histocryl glue to close the vessel. Okay, so this is the same sort of glue that they use in A&E to glue, skin and stuff. Okay, so that's mycotic aneurysms. So I was going to talk a little bit now about dissections. So, as we've just spoken about, this is quite a nice picture of a dissection. So a dissection is essentially where you get a tear in the inner arterial wall, and then the blood flows into that false lumen and creates an intramural hematoma. This can either grow and occlude the vessel, as it looks like it's doing here, or it can go on and re-enter the blood and just cause a stenosis, or you can sometimes get some bulging of the outside of the vessel, and it can cause a pseudoaneurysm. That can either be extracranially in the neck, where it has probably like not very high significance, to be honest, or it can go intracranially and cause a subarachnoid hemorrhage, as we've seen in previous cases. So I've just spoken about all this. So on this part, I was going to focus on the dissection of the carotids, or the verts. It's an uncommon cause of stroke. Only 2% of strokes are caused by dissections. It's usually younger patients, patients that the classic presentation is they've been to the gym, been doing some heavy deadlifts, and they've ended up with a stroke. There are certain predispositions to it, which I think I'm going to talk about a bit later, actually. Classic clinical presentation is the Horner syndrome, which you're all fully aware of, I'm sure. This is a nice example. This was again this year. This was a young woman, 30s, who presented with unequal pupils, and they thought that she was having a stroke. She presented to A&E, and she had a headache as well. So she ended up actually having a venogram. This is a venogram, and it shows really nicely an intramural hematoma. So you can see that this is the carotid artery at the skull base on the right, and this is the carotid artery on the left. And all this around it is intramural hematoma, and there's just a tiny little bit of flow within that vessel. You can see it on the plain CT, which is quite nice as well, because you've got this kind of parapharyngeal fat here, but on the left side you've got effacement of that fat secondary to the intramural hematoma. This was her CTA, which shows the narrowing and thinning up there. And what this does is it causes compression of the sympathetic chain in the neck, because the sympathetic chain runs next to the carotid artery within a sheath, and that's called the vascular sheath. It's called the vascular space or the carotid sheath, and it's a tight, fascial structure, and any blood in here doesn't go anywhere. It just gets contained within that fascial sheath, and the sympathetic plexus runs next to the vessels there and gets compressed, and that's what causes the classic Horner's syndrome. Okay, so that was a nice dissection. Then we can see it here on the MRI as well. You can see there's nothing on this side, and then this is intramural hematoma. And then on the flare, you can see intramural hematoma, and then this is the phloeboid going through that. So the good thing about these is that they present with stroke. So, you know, some of these patients actually present asymptomatically, because they just have some neck pain and they feel a bit funny, and it gets picked up on an MRI. If they don't have a stroke, the natural history of this is pretty good. You know, this is an example from a textbook. Irregularity got worse. This patient was just given aspirin, and then I think, what does it say? 3 months later, the artery is completely remodeled. So these either close off completely, and if they close off completely and they've had no stroke, that's fine, because the rest of the circle of Willis takes over, or they just remodel. This is classic imaging of dissection at the skull base. This is the bilateral internal carotid artery dissection. The classic imaging study to look for an intramural hematoma is a fat-saturated T1 sequence, and that's called a black blood sequence. So if anybody, I mean, I don't know if that would ever come up, but it's something to think about. All right, okay. So these are some examples of, so I tend to, there's no kind of hard evidence as to how to treat these people. If they present with a stroke, you know, they usually get treated as per stroke, bit of aspirin. There's no evidence between full anticoagulation versus antiplatelets in these patients. There was a trial called the CADIS trial, which showed no difference between those two. And that CADIS trial actually showed that the risk of another stroke is actually very low in these patients. Or if they are having repeated large vessel occlusions, there are some people that are very aggressive with these and end up doing all sorts of stuff with them. So this is a case from my fellowship. This guy presented with bilateral carotid dissections. This is a fat-sat T1, like I told you about a minute ago, and these are intramural hematomas bilaterally. This is a DWI sequence which shows strokes in his watershed territory on the left side. So he's got bilateral strokes, but he's only symptomatic on the one side. This was the left side, which shows that the carotid is completely occluded. So this carotid was gone, essentially. So he's got no blood going to his left hemisphere from his left carotid, but he is supplying across the ACOM. Okay, so the other carotid on the right, so this right-sided carotid artery is the sole supply that this patient has to both hemispheres. And look how it looks really irregular, really scraggy, completely dissected. You know, he's living on a shoestring there. This is an interesting angiogram. So this is a capillary phase angiogram, and when you do a capillary phase angiogram, you get the capillary blush, and then this hemisphere is supplied by his right carotid, and then you can see here that this is the watershed territory. The watershed territory here is much higher up, whereas it's been pushed laterally in this on this side, which is an indicator of global hypoperfusion. That's why it's having these. It's because the blood is getting to this hemisphere fine, but by the time it's come up across and it's gone along there, it's not fast enough essentially, and he's getting ischemia. And this guy was on the ward, he was blood pressure dependent. They had to keep him hypertensive on the ward. If he stood up or did anything, he got symptoms. So in this patient, he ended up having both carotids completely stented. This is the left carotid, and that's what it looked like to begin with, and that's what it looked like at the end. So it's completely stented, and ended up stenting both sides. This is another case, a young man. He's got a left-sided stroke. This is a CT perfusion, which shows that he's got all this stuff at risk. There was a small dissection flap here, which was exposing the circulating blood to the vessel wall. Clearly that's prothrombotic. And there was irregularity going all the way up. And then this guy ended up having a load of stents as well. So there's a stent all the way from his carotid bifurcation all the way up to the skull base, overlapping stents to completely reconstruct the artery. So there are people doing, and that's what this one looks like, although you can't really see it as well. People doing this sort of thing. This is an example of a pseudoaneurysm, as I was telling you about. There's a stenosis. These tend to be of little clinical significance. They're not particularly at high risk of bleeding. They just stay like that forever, really. Some people might suggest that there might be an increased risk of stroke because you've got turbulent flow within this abnormal dilatation. And if this patient was having recurrent TIAs, or there might be an indication to try and reconstruct that vessel. Okay, so I was going to talk a little bit now about thrombosis. So I was going to talk about excuse me, venous sinus thrombosis and stroke, and talk a bit about each one, some of the endovascular things about it, just to give you all a bit of an introduction to it, really. So this was a great case that, so venous sinus thrombosis tends to affect more women than men. There's a younger age distribution than people that present with arterial thrombosis leading to stroke. Quite a high incidence in young babies, neonates, premature babies. Most of these patients have underlying congenital or acquired hypercoagulable states. But they can result from local vascular compression, or it can just be idiopathic. One thing to really understand is that if you can sort it out and you can get recanalization, the outcome is better than for people that have arterial infarctions. These are risk factors associated with it, so head trauma, neurosurgical operations, indwelling catheters, dehydration, pregnancies, vomiting, all these pro-inflammatory and pro-nephrotic syndromes and things. Clinically, they can mimic things, so they get misdiagnosed, and they have a late diagnosis. They can mimic a stroke. They can mimic subarachnoid hemorrhage. People can look like they've got encephalitis, or you know, a neurodegenerative disease. This is a good example. This is a young-ish man who also was in Salford not long ago. And you can see here that this is a plain CT head. This has got no contrast in this scan. All this is clot within his superior sagittal sinus all the way down here. His torcular is completely clotted. Straight sinus, vena Galen. Yeah, so all this is completely clotted. You can see his cerebellum, how swollen his cerebellum is. And his swollen cerebellum, this is the CT venogram, which shows all the clots everywhere. Swollen cerebellum. He had an EVD put in at the time, and then there was a question mark as to whether they were going to decompress him. They nearly decompressed him. Yeah, that was the choice. But we decided to try and take some of the clots out endovascularly. So this was his angiogram to begin with at the start of the procedure. So this is a carotid angiogram on the right side, and this is the venous phase of the angiogram. And you know, there's just the veins are congested. There's absolutely no filling within the sagittal sinus, transverse sinus, or the sigmoid sinus. So what we did was we put a sheath in the vein, in his leg, in his femoral vein, and then we went all the way up with catheters all the way around. And then this is a catheter actually on the other side of the torcular. This is a catheter that's in the posterior superior sinus. You use these stents and you drag stuff out and spend about 6 or 7 hours doing. And then he had good flow at the end. And he's done really, really well actually, because I mean, everyone thought he was going to die. And now he's doing really well on a rehab ward, and he's talking, moving, walking about. He was in his 50s. So that, you know, was a really good outcome for him. But it's difficult really, because these guys do get referred, and you know, what do you do with them? So there's some guidance in papers, and this is from the Society of Neurointerventional Surgery in America, which is a kind of cross-collegiate organization run by neurologists, neurosurgeons, radiologists, and endovascular. So essentially the first line treatment for all of these is anticoagulation. If they're in a very deep coma, like that our man was, he was GCS, I think GCS 9 or something, or there's a clinical deterioration despite, you know, a good few days of this, or there's a contraindication to it, then you can consider doing endovascular thrombectomy. Some of these guys get treated with hemicraniectomy. That's what was considered in this case. He was very close to having a decompressive one. Okay, good. Right, and this is just a diagrammatic example of how we do it. So this is a big large bore catheter, and this is sucking the clot. This is a stent, which is capturing the clot. This is drugs being administered, so thrombolysis drugs, so thrombolysis drugs. This is a different mechanism which I've never used, and this is where they've actually deployed a balloon. They've crossed the clot, then they've inflated a balloon, and then they're just pulling it. So it's pretty brutal stuff, to be honest. But the dural sinuses are they're a bit more, they're a bit less, a bit more, what's the word, kind of durable than the arteries. So that's that bit finished, and I was gonna just revert to a different talk that I've done for, this is a stroke, this is a talk on stroke, which I was gonna just show you as well. Just a quick introduction to stroke scans and what this might be a bit simplistic for you guys, but it's just to fill the last 10 minutes with. So this is a talk that I give to junior registrars in radiology about how to look at a stroke scan. I know you guys don't get asked to look at stroke scans a lot, but it kind of comes under thrombosis, and I can just tell you a little bit about thrombectomy, which some of you might be interested in doing in the future. Okay, so shades of grey, you all know this. The brain is shown up with different shades of grey. The brighter, the more dense, Okay, so these are just basic CT head anatomy. You know all this. I'll just skip through this. This is quite a nice thing. So if you're ever looking at your neuro-oncology scans and you want to see where the relambic region is, or the pre-central and the post-central gyrus, this is called the omega sign, and it delineates the central sulcus. You see the pre-central gyrus looks like an omega sign. We used to talk about that. Post-central gyrus. Okay. This is, we call the centrum semiovale. So these are the white matter tracts that run through the brain, and they contain all the white matter tracts, and that's the centrum semiovale, which you'll see in radiology reports. Caudate head, lentiform nucleus, sylvian fissure, quadrigeminal systems, temporal horns. First thing to dilate in subarachnoid hemorrhage, middle cerebral artery. So when we look at stroke scans, we look for signs of early ischemia. This is a hyperdense vessel, so this is clot within the left MCA. Okay. It's a clinical syndrome. Lasting more than 24 hours. I'm not going to go into this. There are lots of different types of strokes that the stroke, these are the different abbreviations that the stroke physicians use. They use lacunar infarcts, total anterior, partial anterior, or posterior. So these are abbreviations that the stroke physicians use. Okay. Imaging, you can get hyperacute changes, acute, subacute, and late. All right, so this essentially, what you're looking for when you look at any stroke scan is basically asymmetry. So you can see here that the caudate is nicely defined, the lentiform is nicely defined, okay? But on this side, you just don't see it as well. The insula's gone, and it's very difficult to essentially delineate those structures, and that's because this has got cytotoxic edema within it because it's infarcted. This is a subtle sign. So this patient, the grey white matter is not too bad, but the subtle sign to show here is that this sylvian fissure is nice and open. Then this sylvian fissure is actually effaced because of the swelling. So you can get subtle signs like that where you get just asymmetry in terms of the CSF spaces. Again, a bit more obvious, loss of the grey white matter differentiation, lentiform's gone. And this is a textbook example of those points which I've just been telling you about. And that's, this is a dot sign. Sometimes, instead of having like an obviously hyperdense MCA, which I showed you earlier, you might just have a tiny little dot within the sylvian fissure. This is the corresponding CTA, where you get the contrast running up and then it abrupts. And then the clot's there. Okay. This is a dense MCA sign. Again, this is from a textbook. CTA shows that the M1 is occluded. All the lenticular striates coming off the M1 will be gone. And then this is a thrombectomy case that they've successfully opened up somewhere. I don't know if any of you are aware of the aspects. Aspects is an interesting. Well, it's a widely used scoring system. It was originally developed to predict the risk of hemorrhagic transformation following thrombolysis. And now it's used essentially to make decisions on patients that present acutely with a stroke as to whether we think it's safe enough or whether it's the risk benefits there to undertake a thrombectomy. It's from Canada. Each area is attributed a point. So this is the caudate, internal capsule, lentiform, insular, then middle cerebral territory, anterior to insular, lateral to insular, posterior to insular, and all that's at the level of the basal ganglia. Then you go the level higher at the level of the centrum semiovale, and then you get M4, M5, M6. And what happens is that when these people have strokes, as I showed you earlier, you get loss of the grey-white matter differentiation involving these particular areas of the brain. And when you can identify that a particular area is involved, you reduce this, you take a mark off. And patients that have more severe strokes have lower aspect scores. So if I just do an aspect score for one of these guys, so if I did it for, say, him, if I was looking at this, just on this slice, I'd have to look at another slice at the level of the central semivalia. You'd see that he's lost his insular, he's lost his lentiform nucleus, he's lost his internal capsule, he's lost the insular lateral to it as well, insular and that. So, I mean, just looking at that, I think he's lost his M1 as well. So just looking at that, I'd say his aspects is at least at best a 5. So that's a severe stroke. Okay. CT perfusion. CT perfusion, I don't know if Reka's already spoken to you about CT perfusion, but CT perfusion is whereby you get an indication of the cerebral blood flow. And what happens is you give the patient contrast, and then you take lots and lots of CT scans over a period of time. And the sequential CT scans, over the sequential CT scans, you get different levels of opacification of the brain, depending on how well that brain is receiving contrast due to any blockages and things like that. And it gives an indication of cerebral blood flow, and you can and transit time taken for the blood to go through. There are lots of these automated CT perfusion softwares now that which actually do all the post-processing and the calculating for you and just present you with like a nice color-coded map. And we use this one in Salford Rapid. So we all have the app. This app is on our phone that we can use. Okay. So this is an example of a CT perfusion map that we use in stroke. And essentially what you're using it for is using it to determine how big the core infarct already is. And that's basically attributed to be dead brain that's not salvageable versus ischemic brain around that core, which is ischemic but not yet fully infarcted. And the suggestion is that if circulation is re-established and that brain becomes perfused again, then it might recover. And they use different parameters, different, mathematical algorithms to determine that. And in this patient, this is his core, and this is attributed to be dead brain, and that core equals about 17 milliliters. But his penumbra, or ischemic penumbra around it, is determined to be 54 millimeters. So there's a big mismatch there. So if this was presented to somebody, then then they would suggest that that might be somebody who would benefit from re-establishing the circulation. This is another example where there's actually no core. This patient has not actually infarcted anything yet, but if they were left, this would result in quite a significant stroke. MRI in stroke. This is just a quick picture on DWI. I'm sure you're all aware of restricted diffusion, and this is a small thalamic infarction. Vascular territories. We've spoken about watershed territories in the dissection case. Right, I'm going to just talk about this, is what we've already discussed. So I'm going to just show you some cases now some thrombectomy cases, just to finish off with. So this is a 78-year-old female. I'm sure you're all aware of the NIHSS, and that's it's a stroke scale that the stroke physicians use. It indicates how severe the stroke is. So 17 is a really bad stroke. Looking at that, you can't really see any obvious areas of ischemia. So lentiforms are both okay. The chordates are there. Insular ribbons look good on both sides. And then you can see that she's got a clot there in her MCA. This is an enhanced no contrast given. The blood, the clotted blood, is denser than the flowing blood around it, and therefore it shows up. The best thing to look at, if you ever need to, is to look at the thin slices for this. This was the CTA, which shows the blockage in the MCA. And then this is a volume, which shows the blockage there. This was the CT perfusion, which showed that this patient, in corroboration with their aspect score, did not currently have an established infarction, but was at risk of a significant infarct if nothing was done. This is the DSA, internal carotid artery. This is the petrous carotid, goes up here. You can see a catheter there, and that's just in the ICA below. This is the cavernous ICA. That shows here that this is blocked MCA here. This is interesting because you can see here the reason why this particular patient is doing so well, despite the fact that, you know, the M1 is gone, is because she's got excellent collateral circulation. In her, you can see that all this area is being perfused, well, almost being perfused by the anterior cerebral territory. Normally what you get is the MCA comes across, and then it fills all the small branches, and then you get leptomeningeal vessels over the surface of the cortex of the brain, and then on the ACA comes across, and then this is the border zone between the ACA territory and the MCA territory, and the anastomose across the leptomeningeal vessels. In this patient, this is completely blocked, so she's got nothing going from her MCA, but she's perfusing that territory across those leptomeningeal collaterals, and these are MCA branches which are filling retrogradely from the wrong direction, but they're filling from the ACA. So just to let you know, that's a bit of dynamics of when you're looking at a DSA. And then we put this is just a big tube to suck the clot out, and then she ended up doing really well, and you can see here that everything's re-established, and she's moved a bit there. And that was the clot. And that was what she was left with, only a small, you know, non-disabling problem in her lentiform. So that's good. Again, 78, 22. So this one's a bit worse. You can see that she's got a lot of the loss of differentiation here. This is the core, and this is the penumbra. Still a big mismatch, but it's a big core. It's a big core. The bigger the core, the higher the risk of hemorrhagic transformation if you re-establish the circulation, because you've got a higher volume of dead brain. This is the same patient. So despite this being a large core, it was felt that the mismatch was great enough in order to give us some value in trying to re-establish the circulation. This was her vessels, so, you know, horrific looking vessels. She's got very tortuous brachiocephalic. This is the common carotid. It goes right down and then up. Then as she gets, so here she's got, so when you're going from some groin, you've got a lot of resistance, a lot of loops, a lot of redundancy to work across. Then what happened here is, this is the tube here. It's gone up, it's gone round. Then as we're trying to get the wire up here, you can see there's some sort of shading there. And then if you look at the lateral, it's all like this. So that's a dissection. And, you know, this is intramural hematoma. This is true lumen. We'll go to the next picture. That's looking like that. Still trying to get across it at this stage. Next picture. That intramural hematoma is getting bigger, and now it's compromising flow in a carotid. Gets bigger, and then the carotid completely closes down. So there's not much to do there now. Here, she has got excellent flow across the circle of Willis. So in fact, she was just ended up with this big stroke, which she was going to have anyway. And the fact that she ended up with a carotid dissection didn't do her too much harm. Well, yeah. Okay, so this is another one. 43-year-old male. NIHS is, you know, still high, medium. We have a cutoff that if the NIHSS is less than 6, then we tend to not do it. It's felt that the risk benefit of undertaking a thrombectomy in those patients is too great. The exception being if they have an aphasia, because that's a very, you know, very disabling symptom, then, you know, we would sort of be a bit more aggressive in those patients. But those patients that have an aphasia, that tends to make them score very high on the NIHSS anyway. That looks like a hyperdense vessel, but it isn't. What I'm showing you here is that he's got some loss of the grey-white matter differentiation in his occipital lobe. There's a little hyperdensity there. On his CT perfusion, he's got no established infarction, but he does have some penumbra or ischaemia in his occipital lobe, which corresponds really nicely with his occipital, with his left PCA territory. You can see here that this is the PCA, and it divides. It goes into the posterior temporal branch and then off into the occipital branch. So that's the PCA, and on that PCA, it just stops abruptly. And that corresponds with that hyperdensity there. Then we had a DSA. You can see here that these are bilateral vertebral arteries, vertebral basilar junction, basilar artery. This is the right PCA, which goes off and supplies the occipital lobe. And then this is his left PCA, which stops abruptly there. And all this isn't on the other side. And that was recanalized, and you know, he did okay. Another stroke, loss of the insula, quite a bad aspects. MCA is completely gone. See how dark the brain is compared to the other side? That's because the capillaries are not full of contrast, because there's a big blockage there. And if you see a patient who's got really good collaterals, sometimes this will look just as good as the other side because the collaterals are working well, but in some patients, for some reason, they just don't have good collaterals, and it's something that isn't really understood yet. People don't really know why some people have good collateral circulation and other people don't, and it's an area of research. Big core, big penumbra. Nothing happened. He had a decompressive craniotomy, but didn't do well. We're nearly there now. So, low NIHSS came down to 0. Clot. So in Salford, we wouldn't have treated this, but I think they ended up treating it. Big perfusion deficit. They ended up treating it in the anticipation that this patient wasn't going to do well. So there's the line of thought that, you know, this guy's got this block in his M1 and he's clearly going to be perfusing across his leptomeningeal anastomoses, and there's the feeling that those leptomeningeal anastomoses do eventually exhaust themselves, and they do eventually end up infarcting, albeit later down the line. So again, there are lots of people doing studies and research, and lots of people are very opinionated about treating people with low NIHSS with confirmed large vessel occlusions. You did well. Okay, we're finished. I can't hear anybody, so I don't know if there's any questions or anything like that. You can email me or anything like that. But I'm hoping you're all still there.
Yeah, we are all here. Thank you so much, Dr. Hilditch.
Okay, good. Any questions?
Hi, Dr. Hilditch, Sean here.
Hi.
Thanks for the talk, it was great.
Good.
Just regarding vessel wall imaging, which you mentioned in relation to aneurysms.
Yeah.
Indications and how it influences treatment, could you just elaborate?
So, at the moment, it doesn't really influence our treatment at all, really. There are some meta-analyses out there that show that it can be of some benefit in some people, but it really isn't being used. And some aneurysms just enhance anyway. the PCOMs tend to enhance regardless of, you know, whether they're about to rupture or not. So at the moment, it can be, so one of the key clinical utilities it can provide is that if somebody presents with, say a young person presents with CT negative, LP positive subarach, and then they do a CTA, and they've got like about 6 aneurysms, or three aneurysms, and you feel duty bound to treat them. You could do some people do vessel wall imaging to see if any of those aneurysms are enhancing, which might indicate that might be the culprit aneurysm that's actually bled. And then treat that one rather than treating all of them, you know, because, you know, some of them might be very difficult to treat, some of them, you know, might not be treatable endovascularly or surgically. So it's being used by some people in that regard. We're not using it for unruptured aneurysms, but it can have some clinical utility as a problem solver in certain clinical instances. So.
Hi, Dr. Hilditch. Thanks very much for the talk. It was really, really interesting. I was just wondering, you know, the blister aneurysms that you talked about?
Yeah.
In what way do they, are the same layers of the vessel wall involved as they are in normal saccular aneurysms? Because I know they're very, very thin and friable, or is it just, you know, is it just the media or just the intima? How are those different?
So I think that rather than, so if you get a saccular aneurysm, they tend to occur at the bifurcations of the arteries, and so they occur at the MCA bifurcation, they occur at the acon complex, and at the origin of the PCOM, things like that, and it's where you get a branch point. Whereas those blister bleb aneurysms occur on the posterior wall of the supraclinoid ICA. So one theory is that they are, in fact, a tear in the vessel wall, rather than an aneurysm forming and then being a weak bubble or weakness of a vessel that eventually bleeds over time. These are an acute tear in the artery, which can occur maybe through hypertension or, you know, I don't know, some local bony anatomy, the clinoid might cause it. And then the aneurysm that you're actually seeing isn't an aneurysm in the sense of a saccular aneurysm. The aneurysm is itself a pseudoaneurysm. It's essentially just a blood clot on top of the surface of that tear in the artery. And that's what makes them so friable and so difficult to treat, because as soon as you start putting coils in, they can rupture. You can't put a clip on them because they're just a blister bleb. And then the only way to really go about treating these is to very, very carefully place a stent and hope that it heals over the next few days, weeks.
Yeah, great. I suppose that would maybe explain why they have a higher blood load as well, if it's...
I think it's because it's a, yes, exactly, because it's a hole in the, the big vessel, the ICA is not like an acon. It's a big high flow vessel, and they've got a hole in it, you know, and yeah, so that's it. So they're quite interesting.
Hi, Dr. Hilditch. Thanks a lot for a great talk.
Hi.
Hi. I just had one question actually. In sort of mechanical thrombectomy and stroke,
yeah,
do you have a particular time cutoff from stroke onset where you'll say, we don't think endovascular therapy is going to be helpful here? Or are you guided more by the CT characteristics?
Yeah, it used to be 6 hours. It used to be 6 hours, and some of my colleagues still kind of attribute quite a lot of weight to that. Whereas I personally, I look at the aspects, and if they've got a good, we don't really use a lot of CT perfusion in Salford. If they've got a good aspects, then I'll give them the benefit of the doubt and do it. I don't really look at the time, I look at the aspects. Because if they've got a good aspects, they've got good collaterals, and therefore they'll probably benefit from thrombectomy. There are 2 trials that came out a couple of years ago. One was called Dawn, and one was called Diffuse, and those were late window thrombectomy trials, which showed, you know, a high proportion of people benefit from thrombectomy after the 6 hour time window. And I think Dawn went up to like 24 hours or something like that. I can't remember exactly how long Dawn went up to, but one of the stipulations for those guys was that you use CT perfusion in order to look for those penumbra core mismatches, and they've got parameters. So I think the infarct core had to be less than 30, and the mismatch had to be a certain amount, and it was different for different ages. You know, and that's what they were using. But a lot of that's driven through the companies because, you know, these automated CT perfusion software packages are fairly expensive, and they like to sponsor clinical trials. But yeah, at the moment, from a practical point of view, and most people I speak to around the world, really, you know, if you're skilled enough to do a decent aspects, you can make a good decision, irrespective of time window.
Okay, thank you.
Yeah. Okay.
I think that's all the questions. So thanks again for today's session.
No problem. Good. Thank you.
Thank you.
Thanks a lot.